So hello, everyone. I'm Emily Farkas, a cardiac surgeon here on behalf of CTSNet, and we'd like to try to tackle some of the ethical questions that surround the COVID-19 crisis today, ones that I think have been on all of our minds. We've got an excellent panel to help us do that. They are respected colleagues, both in their fields as well as in the field of medical ethics. So they've got commensurate titles actually to go along with that. So I think I'll have them introduce themselves so I do them no injustice. We'll start with you, Dr. Fenton.
Hi, I'm Kathleen Fenton. I'm a congenital heart surgeon by training, but I'm currently working at the National Institutes of Health in the National Heart, Lung, and Blood Institute, where I am a deputy branch chief, and I also am an adjunct faculty member of the Department of Bioethics.
Thank you. Dr. Angelos?
Sure. I'm Peter Angelos. I'm an endocrine surgeon at the University of Chicago, where I'm also the vice chair for ethics, professional development, and wellness, and also associate director of the McLean Center for Clinical Medical Ethics.
And Dr. Said?
Yeah, I'm by training, a pediatric cardiac surgeon. I haven't done actual surgery for several years. Instead, I've been working in the field of ethics. I am the chair of the Cardiothoracic Ethics Forum, and at my home institution, which is the Medical University of South Carolina, I'm the director of the Institute of Human Values in Healthcare.
Great. Well, it's a real pleasure to have you all here during this busy time. You know, I think this pandemic offers us a lot of opportunity to teach us about ourselves, our professions, and certainly the public trust which we ultimately serve. I also think it's fair to say that there's been nothing like this, at least in many of our careers, even if you've been involved in military, medical care or humanitarian sector or any other crisis. But physicians have always, by nature, been crisis managers, and really that's irrespective of specialty. I think it only varies based on the magnitude of the crisis. Dr. Angelos, is that the reason that this is so different, this pandemic, for our entire workforce?
Well, I think that's definitely one of the reasons. It strikes me that one of the big differences is that we, especially in surgery, are so used to basing our treatment of patients on the ethical foundation of a patient-centered approach. And so we're generally thinking about what is best for my patient, and I'm, acting as an advocate for my patient. In this current environment, we have to shift our framework. And so instead of thinking about what's best for my patient, we have to start thinking about what is best for the public and what's in the public interest. And so it's very much of a public health ethics basis rather than the patient-centered basis for the decision-making that I think most of us are very used to. And I do think that that's one of the big reasons why this feels so very different and is so very distressing for many healthcare providers.
That makes sense. And just drilling down to cardiothoracic surgery, Dr. Said, you recently wrote a very compelling article sort of highlighting why cardiothoracic surgeons may have a skill set that is quite relevant in a crisis like this one. One of the skills you mentioned was the routine and sustained high-level mental workload in high-pressure circumstances. How do you think that we can best utilize that skill set in this context?
Oh, I think the best way to utilize it is to participate, to be there when the going gets really rough. One of the different, really unusual characteristics of this pandemic compared with previous ones, as Peter alluded to, is the fact that it's come on very quickly and it has threatened to overwhelm intensive care resources in many medical centers. Certainly in Italy, this has been a catastrophic event. So far in the United States, New York is the hardest hit, and they have the unfortunate pleasure of being the epicenter of the pandemic in the United States, when you start running out of critical equipment and supplies, such as personal protection equipment, or PPEs, and ventilators, and ECMO machines, and other life-supporting devices, things get really hairy. And people get very excited, and people, not only in the outside world, are panicking, but people within the hospital start to face situations that they've never faced before. And it does tend to produce a feeling of panic, of unsettling. And of course, this is the kind of situation that surgeons deal with all the time, especially, well, I guess that endocrine surgeons should not be accepted, but especially cardiothoracic surgeons, because we so often face unexpected events that are life-threatening, and we have to react quickly and do so in a calm and considered manner. I think that those are the characteristics that surgeons have, cardiothoracic surgeons in particular, in our case, that can contribute hugely to the stability of the workforce in healthcare centers. So I think that that's one of the major things that we can contribute beyond what ordinary physicians, nurses, et cetera, would be able to contribute.
So Dr. Fenton, in consideration of what Dr. Said is saying, based on the skill set, or do we have a moral obligation then to redeploy as intensivists, for instance, or as ER doctors, or even as an ICU nurse, which some of you know, Joel Dunning, thoracic surgeon, and on the leadership of CTSNet, is actually functioning as an ICU nurse because that's where the need was at his hospital in the UK. A great example for all of us. Is that our moral obligation to do so? That is
a great example for us. I think moral obligation is difficult to say, but I do think, at least I personally feel that I have an obligation to put my skill set to use wherever it's most useful at the moment, and the moment is going to change. I can function as an intensivist. I can probably function as a better intensivist than as an ICU nurse, but certainly, especially as a fellow, but sometimes also in the context of humanitarian work, I found myself really functioning as a nurse part of the time because that was what was needed. I think that when we take the Hippocratic Oath, or whatever version of it we took when we graduated from medical school, we really committed ourselves to put our patients first. And I think that, you know, as Dr. Angelos was talking about, to a certain extent right now, the whole world, or at least the world in our immediate vicinity, is our patient. And I think that we ought to look at it from a public health perspective and do whatever we can. And further to that, the AMA Code of Ethics actually states that commitment to care for the sick requires physicians to provide urgent care during disasters, even in the face of risk to the physician's own patient health or life. And Dr. Said, assuming this is the case, is it fair, though, to ask people in higher risk categories, for instance, retired physicians, perhaps, who may be putting themselves at greater risk than the younger portion of the workforce? Is it fair to ask them to put themselves in the front lines?
Well, let me start at the beginning of your comment. I actually was a member of the AMA Council on Ethical and Judicial Affairs about 12, 14 years ago when we first wrote the opinion that you're referring to. So I'm quite familiar with it. I also am familiar with the part of it that says that physicians have to take care of themselves as well as looking after others. One of the purposes of looking after yourself is to make sure that you can continue to look after patients. I do think that physicians have an obligation to participate for reasons I gave a few minutes ago, especially cardiothoracic surgeons, because of our special skill sets. But there's a limit to that. Kathleen and I were communicating about some of these issues over the past couple of weeks. And one of the comments that she made was that she had volunteered to go to some of the clinics at the NIH where she's working now to assist in any way that she could. And my comment to her was that I think that that was wonderful, a wonderful thing for her to do, but I could not do it. And the reason I can't do it is because I'm 82 years old, I have chronic lung disease, I have a chronic cardiac condition, and man, I'm a setup. If I contract the virus, I'm a goner. And in fact, I'm talking with my wife now about what happens if they offer to put me on ECMO. And my answer to that is don't do it. I'll never come off. Although I think I might do all right on a ventilator, I'm not so sure about that either. So I'm really, really high risk. And for many retired physicians and surgeons, they are in older categories and are at higher risk. And those people need to weigh the increased risk that they have compared with others who are doing the things that could volunteer to do, and decide whether on balance they should be participating or not. In my case, it's very clear that I can't be there. I wouldn't be very useful taking up a ventilator if they give me a ventilator at all. You know, when resources start to run out, it's us old guys and ladies who end up being put aside in favor of giving the life-saving equipment to younger people. So there's no way that I should be there. But young ladies like Kathleen can volunteer and do a wonderful job with it.
Sure.
Emily, if I can chime in, for me, the harder question for physicians in terms of volunteering for something like this is not what I signed up for, but the fact that my family didn't sign up for it. And when we're talking about something that's this contagious, and I'm here living with my dad who just turned 87, if I do end up working in the clinical center at the NIH, helping to take care of COVID-19 ICU patients, I'm actually putting my dad at risk too. And it's something that we discussed, but something also that I think is part of the consideration for all the healthcare providers. You're risking bringing this home to your family.
Sure, I think that's a great point. And especially about what we've signed up for and what we haven't signed up for. And like you said, family members. Another challenge, I think, is clinicians that are being asked to function in a level of responsibility that's higher than what they're accustomed to. For instance, a PA taking ICU call as an intensivist, or as we've seen in New York, where they're asking ungraduated medical students to really assume a physician's role without having any internship or formal training as far as on the job. Is it unconscionable really to ask a clinician to function outside of their normal credentialing? And is it the right message really to send to the public? Dr. Angelos, what are your thoughts?
Sure. It's a great question. And I mean, to some extent, it to me highlights the fact that there is a lot of gradations between what is optimal and what is acceptable. And as an example, I'm an endocrine surgeon, but I'm a trained general surgeon. So, if a patient comes in the middle of the night and I happen to be on call and they have a perforated colon cancer, then I'm perfectly acceptable to operate on them. On the other hand, if they came in electively to get a colon resection, nobody in their right mind would send that patient to me. I mean, I wouldn't recommend it even if they asked. And so I do think that it is a common situation that we do things in an emergency setting that maybe not the things we are most comfortable doing, but are certainly acceptable within the realm of things that we are qualified to do. I do believe that there are a lot of things that we're probably qualified to do that we may be somewhat uncomfortable doing. And to me, in a time of a public health crisis, that's okay. We should do those things that we are qualified to do, even if we're not comfortable doing them. I worry when we're asking people to do things that they are completely unqualified to do. And so, graduating fourth year medical students early and making them MDs it's a formal process that shifts them from a student category to an MD category, but it doesn't actually add much to their qualifications to do things. And so I'm a little bit concerned that that we are putting people in a position where they're not really going to be able to do as much as we would like them to do. And I do think that we need to be sure that we're not fooling ourselves by thinking that every MD is equally qualified to do all of the things that may be asked. So, you know, as an endocrine surgeon, I'm probably much less well qualified to take care of an ICU patient. Now, if I got a little training and had some oversight, I could do it, I'm pretty sure. But it would be very different from someone who's treating critical care patients on a regular basis in their practice.
Sure. And
Yeah, can I just add one comment about that, and that is that that everything that Peter just said is absolutely true, and I agree with all of it. I think though that there might come a point at which there's no one else to do it.
Mhm.
People have gotten sick. They are at home in bed or in a hospital in bed themselves. I'm talking about physicians. And there really isn't anybody else to do it. Well, I think that it's okay under those circumstances to do the best you can, even if it doesn't fit into your ordinary qualifications. And I'm not sure about medical students. I think that they probably aren't much better than the man on the street with very little clinical experience. But for most others, including, I think, all physicians, there might come a time, which I would hope would never happen, but there might come a time when you really ought to be doing something that you feel very uncomfortable with, that you're really not qualified for, but there just isn't anybody else to do it.
Yeah, I have to agree with you. I mean, in that circumstance, you'd be better off with me than with someone off the street. I would agree.
Right.
great points. And you talked about fooling ourselves by these types of decisions. I'm not sure if we're fooling the public either with these types of decisions. And I think another thing that may be misunderstood by the public is our forced decision really to cancel or delay non-urgent operations. There was a CTSNet interview with former STS President Doug Wood recently, and he was talking in the context of oncologic surgery, saying that really cancer surgery is never elective. But another concept that he brought up is, even though it might seem not to be a medical emergency or a medical urgency, it can be a psychological urgency for these patients who are sitting at home thinking of the tumor that they have, unaddressed in their body, or someone with left main disease, I think would be very similar, or high-grade coronary disease. What is our ethical obligation to patients in this scenario for delaying their operations? Open to
In the psychological area, yeah, I can comment on that. I think that when push comes to shove and we're running out of equipment, we're running out of life-supporting devices, that psychology is not unimportant and should not be ignored, but does not override medical issues. I think that someone who has a terrible psychological problem and is facing deep depression because her cancer cannot be operated on until a couple of weeks from now or a month from now, that she's just going to have to put up with it, and we'll treat her depression or whatever the psychological outcome is. But the medical issues of people who are actually dying because of lack of resources need to take a front place before psychological considerations, important though they are.
Yeah, and I completely agree with you. And the one other thing that I would add is I do think it's somewhat misleading for the public when we talk about elective surgery, because I think elective surgery sounds very much like optional surgery. And so at the University of Chicago, we've come to now refer to these cases that we feel we need to do as medically necessary, time-sensitive procedures. And so we've actually developed this sort of a scoring where we look at the procedure, how long it's going to take, what's the likelihood of a prolonged hospital stay, an ICU stay, that sort of thing. We look at what is the likelihood that there will actually be harm to the patient by putting it off for 2 weeks or 6 weeks. And then we also look at things like what's the patient's underlying medical condition? Do they have comorbidities and that sort of thing? And those comorbidities sort of cut both ways, because it may be more dangerous to bring them to the hospital now to have a procedure. But again, all of this we have to consider in a way that we wouldn't have to in a normal situation. And so for me to have to think about my cancer patient in the context of whether someone else is going to need that ICU bed or whether, you know, someone else is going to just need the hospital bed, I think that's a dramatic shift for us. And again, I think that's part of the reason why this is so disruptive, and I think really is causing a tremendous amount of distress by the public as well as physicians.